This podcast represents my opinion and the opinion of my guests. This is not medical advice, and I am not establishing a patient-physician relationship with any listener. The content here should not be taken as medical advice. The content here is for informational purposes only. And because each patient is so unique, please consult your healthcare professional for any medical questions you may have.
Welcome back, everyone, to another episode of the Not Your Doc podcast, our second season. I'm your host, Vanessa, and I'm here with our producer, Seth, and Mr. Not Your Doc himself, Dr. Charles Tadros. How are you doing today, sir?
Yeah, very well. Thank you.
Good. Well, I'm excited about today's topic because I think it's a five-year-old's dream come true. And that is tummy and potty issues. We're going to talk about the potty, people. So, are you excited about that too, Dr.
I do,
Tadros?
it's a bane of a lot of physicians' existence,
Yeah.
so I'm happy to talk about it.
All right, awesome. So, in all seriousness, Dr. Tadros is going to go in depth on one of the most common and burdensome chronic healthcare issues that people experience, and that is stomach upset, stomach issues, bathroom issues. What we're talking about is the constellation of symptoms that frequently get labeled IBS or Irritable Bowel Syndrome. Those include abdominal pain, gas, bloating, constipation, and diarrhea. You can think of a Pepto-Bismol commercial if you need it all encapsulated into one. So I'm going to give us a little bit of context on the size of this problem in our, not the physical size, but I guess the theoretical size of this issue before Dr. Tadros takes over and gives us some more specifics about the disease itself. So these symptoms are the number one reason for a trip to the GI doctor, accounting for millions of visits per year, whether it's, hard time going to the bathroom or constant abdominal pain, gas, whatever, millions of visits per year. These symptoms are thought to affect 10 to 15% of Americans, and it typically affects a higher proportion of women than men. And they are extremely costly in terms of dollars and resources spent. And this includes direct and indirect costs. So direct costs meaning, doctor's visits and treatments and medications and hospital stays and all that. And indirect meaning loss of productivity, in the workforce, people not being able to participate in activities, and quality of life declines as well. A conservative estimate of those costs combined, both indirect and direct, are $22 billion a year in the United States alone. So my source for these last few things there is the International Foundation for Gastrointestinal Disorders, which Dr. Tadros pointed out sounds made up. But I found a couple of other resources to cross-reference this with, and the $22 billion per year is an estimate that several other sources shared. So this is a big problem, right, Dr. Tadros?
It is. It's expensive. It's time-consuming. I've had people not be able to leave the house generally for social occasions for years at a time because of this.
Yeah, it can really impact people's quality of life. And, you've told us before that it's up there with low back pain and tiredness and fatigue in terms of how common of an issue it is.
Yes.
Can you just tell us more about why you wanted to discuss this topic today?
Well, certainly, as you mentioned, it's the number one reason to see specialists, a GI specialist. It's a terrible name, GI and gastroenterologist. There's a gastrointestinal enterologist. But anyway, so that's a specialist. That's a specialist who trained like I did in his internal medicine, then went on after that to do a fellowship in just about the bowel and the pancreas and the liver. So that's what their specialization is. Takes up, those are expensive guys and gals to see. They run expensive tests. And when I was back in med school back 35 years ago, This was all lumped in as a kind of a wastebasket term as a functional bowel disorder. But over the last 30 years, we've kind of separated out some of the signs and symptoms that some people will get and used to be lumped under the functional bowel disorder or irritable bowel syndrome, which is different than inflammatory bowel disease, which is a different thing.
Yeah.
But irritable bowel syndrome. But now we have other diagnoses that are much more that should be treated differently than just what we do with irritable bowel. So we can come back to that.
Yeah, absolutely. So were stomach issues and just, functional bowel issues things that you problems you observe frequently in your own patient population?
Yeah, it's very extremely common. Men and women, certainly I have it. And as you mentioned, women on average have it more than men do. It can be associated with a whole host of issues from trauma to anxiety, which is neuroses. The old term is neuroses, to depression, and can be associated with stress. Yeah.
Absolutely. All right, so let's start with with some symptoms. Okay, you kind of gave us the definition, that functional bowel or motility disorder, and the symptoms often overlap with other diseases. So we're going to kind of get into that a little bit more later. So let's start with symptoms. Common symptoms being abdominal pain, bloating, gas, constipation, diarrhea. Talk to us about the red flag symptoms that are associated with this too.
Yeah. So the other thing I should mention besides abdominal pain, which includes cramping, and that's a key feature for a lot of people, and we'll come back to that. But the red flags are just reasons to stop, kind of as you can imagine, it's like a red stop sign or a red light. Stop, and this is a sign of danger. So if anybody's having abdominal discomforts, whether it's bloating, constipation, cramping, etc., and you have fevers or chills, then we have to worry about stuff like infection and inflammation. It's not just irritable bowel or spastic colon or nervous stomach. So certainly red flag symptoms are fevers or chills, night sweats. Night sweats come with certain tumors and some abscesses, persistent nausea that's not relieved with emesis, doesn't feel better whenever you puke, bloody stool or black stool. So it turns out that oxidized blood, oxidized iron is black. It's black and sticky like tar. I know I'm getting gross here, but it's actually sticky like tar. And
we told y'all it was the potty episode. We got you covered.
We got a potty mouth. And blood. And the blood could be anything from bright red. Some people say, it's bright red, it's hemorrhoids. Not always. Bright red to kind of maroon or kind of a darkish, deepish, like a brick red. So far, fevers and chills, night sweats, persistent nausea that's not relieved with throwing up, blood in the stool. It could be even blood without stool. Black stool. This is a sticky like tar, and then loss of appetite or weight loss. So this is a tricky problem because a lot of people are happy that they're like, I don't feel as hungry, and by golly, people are telling me I look good.
Great.
I look good. And that's a bad sign. It's one thing to struggle and to diet, exercise, and look good. It's another thing to lose it when it melts off of you and you haven't even tried. Bad sign if you're not trying to lose weight and you're losing weight.
Wow. Okay. I definitely, in our discussions preparing for this episode, I was definitely intrigued by some of the past treatments and explanations for some of this stuff that you shared. So as you said before, this can, IBS is kind of, or functional bowel motility or whatever, can kind of be a wastebasket diagnosis, like an easy diagnosis that isn't very specific to a cause. But what were some other, past ways of thinking about and treating this? I mean, obviously you mentioned neurosis and, spastic colon and stuff like that.
Yeah. So certainly in the old days, we used to do all sorts of, even before my time, people would get enemas, if they were constipated. People were given Valium because of their neuroses or anxieties, which actually could help, by the way, where we actually use some products like that. People who are constipated, besides the enemas, they would get mineral oil enemas, and they would have to cascara and other things that they would swallow. That was horrific, terrible things. A lot of children have issues that are emotional that are related to the bowels.
Yeah.
So kids that want to control things that will control their bowels, and certainly if kids are not eating enough fiber, not enough fluids, not active enough, they'll tend to be more constipated. But a lot of parents fixate on the kids' bowels, and the kids, of course, become neurotic about their bowels. and there's a lot of struggle about, first of all, potty training, but eventually that the kids won't go, those kids will sit for a half hour on the toilet, not have a bowel movement and stuff like that, and they end up in the pediatricians and pediatric GI office.
Right.
Now, some kids have congenital, they're born with certain very severe issues that can cause bowel issues, but vast majority of kids that are having struggles with their parents about bowel issues are functional and emotional and stress related.
Sure. I know, as we mentioned at the outset, this tends to affect females more than males. So females are typically almost written off as there's just this neurotic female issue, not necessarily an actual medical issue that they're experiencing.
Yeah. So physicians, I'll out a bunch of physicians, including me. Physicians, whenever it comes to headaches, abdominal and pelvic pains, low back pains, all these physicians kind of roll out. A vast majority of these are not lethal. A good chunk of these are chronic. And a good chunk of these it just take up quite a bit of time from the physician. Sometimes these patients end up with multiple ER visits, multiple specialists, et cetera. Women are more complicated than men in several ways when it comes to pelvic and abdominal pain because of the ovaries and the fallopian tubes and the uterus, and the menstrual cycle is more complicated than what guys have to put up with. So it adds another level of complexity. So women can see a urologist for their kidneys and bladder. They can see a GI doctor for their intestines and their liver and their pancreas, but they also have to see a gynecologist. So they have another layer of complexity.
That shouldn't be dismissed, right?
should not be dismissed. We should be able to treat everybody. We should be able to improve, maybe not get rid of, not cure, but we should be able to improve people's lives.
Sure. Yeah, I agree with that. Okay, so one thing that you had mentioned before for a treatment, I think, was doing a rigid scope. What was that about?
So well before we had flexible, people don't realize this. Well before we had a flexible, so your EGD, upper esophageal gastroduodenoscopy, way back in the old days, and actually sometimes now for cancer surgeries, instead of a flexible scope.
Okay, I need you to back up there. What is that?
Yeah.
Put a scope through your mouth, down your esophagus?
Right.
Okay,
All
right.
Yeah. So esophageal gastroduodenoscopy, EGD. So esophagus is the first part, back of your throat, from the back of your throat down to your stomach. Yeah. And then your stomach is gastro, and then duodenum is the first part of the small intestines after the stomach. So in the old days, we used to have rigid. They couldn't do rigid all the way down through the duodenum, but they would have to scope esophagus through a rigid scope. Sometimes they actually have to do that nowadays for.
It's like a straight pipe down here.
straight pipe, rigid. Yeah, you have to kind of work hard to get it down there.
Freaking torture device.
It is a torture device, and the same thing. So for certain surgical procedures, they need a rigid one. But in the old days, we did not have flexible optical scopes.
Yeah.
With the fiber optic scopes. Nowadays, you can they're wonderful full color pictures on a video screen above your head, all sorts of wonderful things. And the same thing with a colonoscopy. We certainly couldn't do the whole colon with a rigid scope, but first a little bit a rigid sigmoidoscopy.
Oh boy, what a time to be alive!
Yeah,
it's a much better time.
We're 1,000
to have
times
IBS.
better, and we have propofol where we can knock we can knock people out. Not every country, by the way, has the same. Will pay or has the same. So in Europe, oftentimes they can do a full colonoscopy, all 5 feet, without anesthetic. So I'm glad to be in America in a lot of ways.
Yeah.
Anyway.
Goodness gracious. Okay. So that was then. This is now. Today's approach, it takes a lot of time and effort to identify the root causes, right? And many docs aren't going to even explore half of the causes or things that we talk about today because limitations on time and knowledge, right?
Well, it is, but also if they try to go by your history, if you could eat bread fine without any gas or bloating, it's unlikely that you're going to have any gluten problems.
Okay.
So
yeah,
they could eliminate that set of tests.
Sure. Okay, so the diagnostic sequence or whatever essentially starts with a visit to your primary care physician or urgent care with your whatever your complaints is, and the clinician is going to look for specific and or emergency causes first, right?
Yeah, the red flag symptoms, by the way, the feverish, chills, night sweats, persistent nausea, blood in the stool, black stool, loss of appetite or weight loss, unintentional weight loss. All that stuff that's urgent stuff, whether your primary care or your GI doctor or sometimes an ER, depending if it's fevers and chills, you can't see your doctor for the weekend. Sometimes it's the emergency room, unfortunately. So yeah, that's why we have red flag symptoms, and those need to be ferreted out early because that's not irritable bowel.
Yeah.
None of those should be irritable bowel at all.
Should we say that these are typically like chronic issues that most people like?
No, yeah. Some of these are from the red flag symptoms. Some of these are acute.
Sure.
So they're fairly acute. Most people don't have weeks and months of fevers and chills. They'll come in sooner.
But they might have weeks and months of just loose stool and stomach cramps and constipation and stuff like that. Okay.
Yeah, I'm talking about the red flag symptoms. That's right. Usually they're more. Yeah, the only one that slides by us in the red flag symptoms is weight loss. Some people will lose 10, 15, 20 pounds and nobody will notice. 30 pounds, nobody will notice, or they'll compliment you how good you look and stuff like that. So that sometimes can go for months. But typically, if you're having black stool, blood stool, we tend to hear about that fairly quickly.
Yeah, absolutely.
I hate to tell this to people because people are going to make fun, but check your toilet whenever you, and I'm going to step around and I'm going to talk about something else in a second, but just, you look at your skin, you look at your face, you look at your tongue, whenever you brush your teeth, stuff like that. Look at your stool before you flush it, before you bury it with toilet paper and stuff like that. You don't have to do it every single time, and you don't have to do it whenever you're having symptoms. I want people to check because some things are silent, and we can come back to that stuff. But just like, we just happen to look at our hands a lot because they just happen to be in front of us. We wash them, we can return them.
Skin on our faces, that kind of stuff, yeah.
So people tend not to check their stool. I'm not telling you to grab baggies.
Right, sift through it.
And mush through it or bring me samples.
Has that happened before?
I am not kidding. Every doc in the universe has had somebody bring them a sample from their home toilet, and we can come back to that another day.
Right.
Anyway.
Okay. Yeah, but just pay attention to changes, obviously, right? Okay. So the visit to your primary care physician, you're not a GI doc or anything yet.
That's right.
So if the issue is found to not be specific or emergency, it's an urgent issue.
Right.
Typically they'll start by suggesting lifestyle or diet adjustments. They'll prescribe a medication or like a barium enema, etc., something like that, right?
So you're jumping kind of ahead. So history and physical, it's just like anything else. History and physical, make sure how chronic it is. Some things are acute, and some things are much more chronic. Gas, bloating, intermittent loose stool, and that type of stuff. Cramps. Oftentimes it's chronic, intermittent. It's not every single day, not every single bowel movement, not every single meal. So they have to get that because that helps focus in the differential. And then typically, some people get rectal exams. A lot of times you don't need it. Basic blood work, just to make sure that there's nothing going on. Basic in terms of your white cell count, your kidney and liver numbers, et cetera. And oftentimes, if it's just like we said, just young middle-aged people that are otherwise healthy, no family history for anything bad, inflammatory bowel disease like Crohn's or ulcerative colitis or family history of cancer, then typically it's higher fiber, whether it's higher fiber foods or actually fiber supplements. I don't like the capsule ones. I tend to have the I'll use name brands, Citracel and Metamucil. This is called plant psyllium, and it's undigestible fiber that tends to attract water, so it bulks up. It's called bulk stool softeners. They bulk up in your colon, and your colon squeezes them through, and it helps you get more regular bowel movements.
What's the difference between something like that and like Miralax?
Yeah. So the most natural thing, which is what our food is, and if they concentrate it into a capsule or into a teaspoon of powder, that's what I want people to use. So Miralax and other products tend to draw water in, but it's not necessarily a natural product and stuff like that.
It's not bulking up your stool, which might be more the issue if you're having chronic diarrhea or something like that.
So so bulk stool softeners is what our favorite choice is. You can't quote unquote overdose on bulk stool softeners. That's the benefibers and the citrus Nutricells and the Metamucils of the world. FiberCon, I think, is mainly capsule. I tend not to use it because it's not enough bulk.
Sure.
Like that. Mm-hmm.
Okay. And obviously you can get those nutrients from a whole grain and leafy green vegetables and stuff like that too. And improving your diet
That's how we
important.
normally get it. That's correct. It's whole grains and other vegetables.
Yeah. Okay.
Fibers, vegetables.
So so what about medications? Is there is there a medication that might be reached for, once it's sort of established what's going on?
Sure. So if you're having, it depends on if you're having more diarrhea, more constipation, more bloating, but there's medicines for cramps. So there are antispasmodics, anticholinergics. Some of the typical name brands is Levsin or Levsin or hyoscyamin. It's also called hyoscyamin. Bentyl is another one. Those are typical anti-cramping medications. So if that's cramping is the biggest problem for you, that's the first thing. If you tend to have more constipation, so cramps, and you feel like you have to go have bowel movement, but there's not much bowel movement, or you small pellets, or you feel like you defecate, but you don't feel like you evacuated enough. It still feels like you still have to go. You have to still have to have more. Then there's some ones that came out several years ago that are more sensitive, Amitiza and Linzess. These help the colon contract and squeeze out more. And you could combine these. You can use fiber plus Linzess, so you can do more than one thing at once. The typical natural stuff, like I said before, so it turns out fluids, I call it fluids, fiber, and fun being exercise. So fluids, drinking plenty of water, because you want to make sure not only, water certainly goes through your sweat, through your breath, and through your kidneys, but also you have water in your stool. And that's helps. So that's fluids. And I don't think there's any set amount. People say 8 or 12 glasses a day. I don't think that's the issue. Drink more if you're constipated. So that's water. Fiber, like I mentioned, whether it's in your diet. And I tend to be, and I know a lot of people love their Vitamixes and stuff like that. I tend to want people to eat stuff. I don't want it to be mulched for you. So I know people. I love Vitamix. I love the soups and stuff like that. But I'd rather have people, I'm not telling people to eat raw everything, but I'd rather have people chew their instead of drink their fiber.
Sure.
Certainly fiber supplements is separate, but I'd rather have them, if it's going to be part of their diet, I'd rather have them do it.
Yep.
If you're not going to have anything done at all, you're never going to chew, fine, put it in your Vitamix with your
smoothie.
Kale and make your smoothie. Yeah.
Okay, gotcha. So those are kind of like the typical first line things. If those things aren't helpful, then what's step 2?
Well, certainly, if people are not getting better with we think it's irritable bowel, and they're not getting better with the typical irritable bowel symptom treatments, then typically we need imaging. And that's the next thing. It depends where your symptoms are. If it's lower abdomen, then colon. If it's upper belly, like heartburny and bloating up high, and feeling full and stuff like that, then upper endoscopy, sometimes both. That only covers the first 3 or 4 feet from above and the last 5 feet from below.
Yeah.
So in between, you have maybe another 18 feet of small intestines that we can't see. And so for that's a little harder to get to. There's something called capsule endoscopy, where you actually swallow a camera that's in the form of a capsule, and you swallow it, and it tracks it down, takes pictures on the way down, and you poop it out and you return it. So there's a giant scope that we used to use in the old days. Then there's also some CAT scans with where you swallow barium with contrast. You swallow contrast, and it'll track it down. So there's different ways to look at the small intestine. So the first 3 or 4 feet is your esophagus, stomach, and duodenum. That's an upper endoscopy or EGD, and then your colon is the last 5 feet, and then in between you have the small intestines. Yeah.
Got it. Okay, so that was kind of a very brief overview of like today's approach to treating this. Now we're going to get into causes, because that's really the interesting part. And we said before that there's so much overlap in these symptoms with other diseases that,
right.
Lots of different things can account for IBS symptoms in general.
Right.
And you wrote a great blog post on your Not Your Doc blog about IBS as kind of the basis of today's episode. So when I was reviewing your blog post, it seemed to me that the causes for these symptoms kind of break down into 4 categories. So we had infections, inflammations, malabsorption, so the body's inability to absorb a necessary nutrient, right?
Or something. It
Or
doesn't have to be necessary.
something,
Right,
sure.
right, some product.
And anatomical issues. Does that ring pretty much true?
That's right.
Okay, those categories. All right, great. Can you, before we get into the specifics of these, can you give us like a brief definition of what each one of those things is? So an infection, inflammation, malabsorption, anatomical issue.
Yeah. So our mouth has germs. Our esophagus doesn't have many germs. Our stomach doesn't have many germs because it's got a lot of acid that kills germs. So our mouth has quite a few germs, and not much in our esophagus and stomach. Not much in our small intestines. A small amount of small intestines, like 18, 20 feet. That's our duodenum, jejunum, and ileum. And then our colon's got massive amount of germs. That's why your poop has bacteria, and that's why you wash your hands after you wipe and stuff like that. So it turns out that whenever people have infections, and so you could certainly have dysentery. This is acute diarrhea, lots of stuff like that. We're not talking about that. That's acute sickness with some sort of bacteria. Sure. That's an acute problem. But some people can have some low grade chronic issues that can mimic irritable bowel.
Gotcha.
So one of them is small intestinal bacterial overgrowth. Is SIBO, SIB for boy O, SIBO, small intestinal bacterial overgrowth. Remember, the small intestines doesn't have much bacteria, so there's an overgrowth of bacteria from their colon seems to seed and overgrow in the small bowels, and that can show up as bloating and gas and feeling full, and even some people severe cases with weight loss. They can have diarrhea, not usually constipation. You can have constipation, but not usually. But these people can even have bloating and weight loss. So that's SIBO. And we actually can diagnose that with a breath test. They give you a special type of sugar, and they check either for hydrogen or methane, if I remember correctly, in a breath test that you do. And then they could treat it with antibiotics, with sometimes probiotics or prebiotics, and some other things like that. SIBO tends to be increased in small intestinal bacterial overgrowth, tends to be increased in people who've had intestinal surgeries, like Bellroth 2, Roux-en-Y, other blind pouches. So that's the first thing. People who've been on antibiotics sometimes will have SIBO. And sometimes people who are stressed sometimes will have SIBO. So those are some of the reasons.
Before we get into the other specifics, let's just say that an infection is caused by a virus, a bacteria, or parasite, right?
Yeah, or fungus. Or fungus.
Those are kind of like
yeast.
the basic issues that are right. Okay.
Right.
And then inflammation is an autoimmune response, correct?
It could be part of an infection. It could be part of an immune response or autoimmune response. That's correct.
Gotcha. Okay. Then malabsorption is just an inability of the body to absorb.
Suck out whatever you put down in there, and whether that's how part of laxatives work. They stay in your intestines. They draw fluid into it, and they make your intestines squeeze out the stuff. So
it's not getting absorbed into your bloodstream and put to work in your body. It's just passing all the way through the system, right?
That's right.
Okay, and then an anatomical issue would be some physical anatomical issue with the structure of your body, structure of body parts and organs related to these things, right?
That's correct. You got it.
Cool. So let's get back into infections. So we kind of covered SIBO. We've got tell us more about these other ones.
So small intestinal bacterial overgrowth. We've kind of become familiar with them in the last 15 years or so. And so you could be placed on special antibiotics that help them. Sometimes they're chronic and they can't clear it, but you can sometimes treat it with certain types of diet, FODMAP, and we can make a link to that. Certain types of diet with that have decreased type of sugars and that tend to be fermented. Diverticulitis. Now, diverticulitis oftentimes is acute. It's pockets in the colon. Just think of if you took a finger inside the colon and just pushed out, but didn't rupture all the way through. It'd be from inside the colon pushing out. So these sometimes can become acutely infected. Like it almost feels like appendicitis, but it's on the left lower pelvis and left lower belly instead of the appendix is on the right hand side of your body. But some people can have a low-grade stuff.
So what happens there? Just material gets caught in this little out pocket, and it doesn't clear out, and it starts to ferment, fester.
Festers.
Okay,
That's right.
yeah, all right.
So usually we don't think of it as so much chronic, but acute. Then the other thing which we don't see very much in the United States is GI parasites. So some parasites, obviously, within 7 days of leaving Mexico, let's say, you'll get diarrhea in the United States. You're there for a week. You don't get so much diarrhea there, but you get it once you get back. Oftentimes, that's not E. coli or salmonella. That's Giardia.
Giardia can be in tainted water supplies, right?
That's correct. You can see it on farms. You can see it on well water, where people have to, they bring up their own well water on their property. It's not treated properly and stuff like that. It's a parasite. There are other parasites out there that can do this, but Giardia is very common. And I had my version of Giardia, my Giardia whenever I came from Mexico 20 years ago.
Oof.
When I visited Mexico and came back home. Yeah.
Yikes. So if I go to the doctor and they suspect it might be some sort of infection, typically this is going to be like an acute onset, right, of some of this stuff.
Some of it's acute. Some of it, it's not, the diverticulitis potentially could be acute. SIBO may not feel that acute. And chronic Giardia would have been acute, diarrhea and stuff like that, and but then it may go away, kind of away. Then you're left with kind of this kind of grumbly stomach with sulfur belching. Smells like rotten eggs sometimes. So initially it may look acute, then it seems to get better, but then these things linger.
Interesting. So because they can linger for so long, do some of the infectious causes get missed then?
Yes, they'll get missed. Yeah, not too many people. We'll catch the Giardia. They'll say I was in Central America. I was scuba diving.
2 weeks ago.
Yeah, 2 weeks ago, and it's pretty easy to get stool samples, and even if they're not positive, because sometimes you can miss parasites because they sometimes are not shed into the stool regularly. Even if you miss that. You can still treat empirically because of the risk and the symptoms. You can see if they improve.
Yeah. Okay. Very interesting. All right. Let's move on to inflammations. Inflammations.
Yeah, we talk about irritable bowel IBS, and one that's very commonly confused with is IBD, so inflammatory bowel disease. And inflammatory bowel disease can mimic IBS, and the inflammatory bowel disease is Crohn's. Ulcerative colitis and microscopic colitis are several different types, but these are things that are autoimmune. The immune system is attacking the intestines in this case, and antibiotics don't directly help. Usually, steroids and immune suppressants and other immune modulators. But you can have, like, for instance, Crohn's, you can have small patches of it in your small intestines, so it's not easy to find on upper endoscopy and not easy to find on colonoscopy, but you have patches in your small intestines. You may not bleed from them, and you may have, diarrhea and abdominal pains and gas and bloating.
Interesting.
So it may mimic irritable bowel.
So the severity of these things kind of lies on a spectrum, right? There can be mild versions to very severe versions.
Very severe, life-threatening versions. Yeah, life-threatening versions, yeah.
Okay.
The next one is gluten enteropathy. So gluten is a product that's found in barley and in wheat and in a bunch of other products that we grow. And unfortunately, it's in a lot of products that we have in our shelves in our refrigerators. So some soy sauce, some of our capsules some of the capsules, our vitamins and capsules will have gluten in them. It's used as a thickener, as a binder and thickener in foods and stuff like that. So it's not just in bread, but it's typically most people talk about it as in bread or in wheat. And so some people, and it runs in my family, have celiac sprue, which is not, we'll talk about intolerance, but this is an actual autoimmune disease where your body attacks your intestines when it's exposed to gluten.
So gluten's the trigger.
Yep, that's
Interesting.
right. For the autoimmune, and so these people classically in med school we were taught that these people will lose. They look like they're malnourished. They'll lose weight. They'll have diarrhea. They'll have malabsorption of vitamins. So they'll have vitamin deficiencies, iron deficiency, sometimes anemia. They can have extra GI outside the GI symptom area. They can have other problems, psychiatric problems, depression, and stuff like that. And if it's undiagnosed and untreated, and the treatment I'll talk about in a second, they can go on to have small bowel lymphoma. So the intestines can get lymphoma.
Wow.
So the treatment, unfortunately, we don't have pills or anything like that. We don't really use steroids or immunosuppressants for these people. They just have to avoid gluten, and not just to avoid gluten, just like by not eating bread. They can't have lots of soy sauces. They can't have certain pills or capsules. They can't share the same cutting board or the same toaster. They're going to use gluten-free bread. Wow. They can't share the same toaster. They can't share the same knife. You could wash it and stuff like that and give it to them. But the problem is this is what we call cross-contamination.
Right.
Whenever you touch. If you open up a peanut butter jar and then because you spread it on bread, the knife goes back in the peanut butter jar, it takes some of the bread and the gluten in with it, so they can't even use that. They have to have their own.
Sure.
So they'll feel better within a few weeks of stopping gluten. These people are so sensitive. Just a few micrograms is enough to trigger a whole immune system response.
That's insane. I think it's important to mention here that, we've got these 4 categories that we've broken up things into, but they overlap frequently. Yes. So gluten enteropathy, for example, is both a malabsorption and an inflammatory response, correct?
That's right. Yeah, that's right. They won't absorb and stuff like that, yeah.
Okay, great. Keep going.
Then endometriosis, which we sometimes forget. Oftentimes women, this is for women, the lining of the uterus that's between the cervix and the fallopian tubes is the uterus. The lining of the uterus that cycles with the menstrual cycle, right? It thickens, and then it waits to receive an egg that's hopefully fertilized. If not, the egg in the lining of the uterus gets dumped out as part of the menstruation. But sometimes this lining will actually escape the uterus, and we typically think it goes up through the fallopian tubes, and it can implant anywhere. It can implant in your brain, in your lungs, in your abdomen. So these people, whenever they menstruate, whenever they cycle, and they kind of build up the lining, they'll build up the lining, the little piece of lining that's stuck on your liver or on your lungs or in your brain. And then whenever if an egg doesn't implant, it's not fertilized, it'll slough the uterine lining, but it will bleed in those other spots.
Yeah,
also.
What a wild condition.
Yeah.
Is that triggered by the hormones?
Yeah, so we don't fully understand. Certainly, it seems to happen in people that have had pelvic inflammatory disease, PID, seems to be an issue with some of these, and I'm not sure some of the other risk factors. But it's interesting to me, but it's a horrible thing.
Interesting, but wild and horrible.
That's
yeah,
right.
Absolutely.
And you can regulate, right? Like you mentioned, you can regulate these people where this endometrium has spread into their body by putting them on birth control pills, because that will respond to not cycling. We want people not to cycle,
right,
and stuff like that. So you can go in and laser. You can go in and laser off areas if they're accessible and stuff like that. But it doesn't mean that it's all gone. It could cause adhesions in the abdomen, so the intestines gets trapped by adhesions, by scar tissue, and you can have bowel obstruction, etc.
Oh, man, so that one's both anatomical and inflammatory, right?
Right. Okay. And so you can imagine whenever this stuff, it won't attach on the inside, but on the outside of the intestines and stuff like that, and you can imagine that would irritate, bleeding from the outside, attached to the outside intestines could cause abdominal pains.
Of course.
Yeah.
Okay.
And then something called mast cell activation syndrome, but not everybody believes in this. MCAS, MCAS. Mast cells are a type of white cells that you have that are involved in inflammation and are part of the immune system, and it can have a whole host of signs and symptoms. Everything from people that can have cause people to feel everything from fibromyalgia, like muscle aches and depression, but these people can have irritable bowel like symptoms. So that's the other thing that you can sometimes see with mast cell activation in some of these people. So that's some very specialized people out there, sometimes allergists. This is different than there's some very severe cases that you can see allergists for and stuff like that. But sometimes there's some other physicians out there that do work with the mast cell activation patients.
So kind of as we saw with infections, they can can these inflammations be sort of like long-standing conditions that cause some of these things? So
Absolutely.
Again, could be missed, right?
That's right. It's mistaken or missed.
Yeah.
Or it doesn't quite fit the pattern that we would expect to see, and people will ignore one or two things that are not in the pattern. So yeah.
Okay. Wow. Let's move on to malabsorptions.
Sure. This is very common because it includes a lot of artificial sweeteners like what a lot of us use. So fructose intolerance so it's a type of sugar. Lactose, which is sugar in milk products.
Fructose is a sugar in fruits,
that's
correct?
Right. That's right. That's right. That's natural. That's part of the problem.
Sugar,
That's part of the problem. It's like, well, I'm eating my natural natural. I'm not adding any sucrose or table sugar. But the end result is some of these people can't tolerate fructose and they can't eat fruits, certainly not in quantities, and not have malabsorption, where you can't absorb it. And you could do fructose intolerance. You could also diagnose this also with a breath test, a special type of breath test. Lactose intolerance is pretty easy because you just stop milk and cheese and ice cream, and your gas, bloating, and diarrhea tends to get better. Raffinose, which is legumes or beans and cruciferous vegetables like broccoli. So some of these people intolerance. Then the artificial sweeteners. Unfortunately, we like all this. The pink stuff, which is sweet and low.
Aspartame.
Yep, that's right. Sweet. The pink stuff is sweet and low, which is saccharin. The blue stuff is equal, which is aspartame, and the yellow stuff is Splenda, which is sucralose.
Sucralose, that's right.
So those three are why they're non-calorie sweeteners is because you don't absorb them. And they're sweet. They're super sweet. They're sometimes sweet to the point of bitter, but then you don't absorb them. But unfortunately, some people are so sensitive that they end up having diarrhea and gas and bloating. And so that's one of the problems. Actually, there's a whole interesting thing we should talk about later with some of these, how they may affect the gut microbiome.
Right.
And so it'd be interesting. And then there's a whole group of people that are gluten intolerant. We talked about gluten enteropathy or celiac sprue, where it's an autoimmune disease. We have a whole group of people where they feel shitty on gluten, terrible on gluten. They feel more depressed. They gain weight. They have more skin problems, more muscle aches. But you test them for autoimmune disease against gluten, and there is none. But they sure feel a lot better. They don't have to be as perfect about avoiding gluten. But they sure feel a lot better. And
so it doesn't trigger that inflammatory response or that autoimmune response that you'd see in celiac sprue, but it's still, you can't absorb the gluten. Yeah.
And then some physicians and some GI people believe that there's no such thing as gluten intolerance, but I firmly believe that these people would not, have to restrict their life in order to try to feel better if they could help it.
Yeah, absolutely.
So I really believe that it probably is real. And so from there.
Yeah. Okay, so malabsorptions, are these all pretty straightforward to test for?
You could, so it's
some of them are just elimination, right? If you eliminate them and you feel better, that's kind of how you know.
Some of them are very basic elimination diet. Most people can handle, table sugar, sucrose. So they'll do a couple of weeks if they really, really need to have something sweet. They'll have sucrose and they'll stop their artificial sweeteners and see how they feel and stuff like that. It's easy to avoid beans and
broccoli,
cauliflower and broccoli.
It'd be my husband's dream if we could avoid all those foods.
Well, unfortunately, cruciferous vegetables are probably some of the best in terms of cancer fighting agents. Are probably some of the best in cruciferous vegetables.
Yeah, so hope you don't have that raffinose intolerance. Okay, so we're going to move on now to anatomical, and there are quite a few of these. Yeah.
One of the problems we run into is gallbladder disease. In the Western world, we have quite a bit of gallbladder. Well, we should say what the gallbladder is. The gallbladder is not your urinary bladder. That's one thing. So your gallbladder sits underneath your liver. Your liver is if you're standing up, and your hand is on the right side of your body. Your right hand is down the right side. If you bring your hand up and underneath your right ribs, it sits your liver. Underneath that sits your gallbladder. Your gallbladder is, I call it a soap dispenser. Your liver makes the soap. It makes the bile, which is the gall, the old-fashioned word, gall. And so it stands there, and as the food comes down the pipe from your mouth through the stomach, through the small intestines, your gallbladder sits there and squirts bile to emulsify your fats. So it breaks up your fats.
Oh, okay.
So that's how it works. So your liver makes the bile, but it's actually because you're not eating all the time, you're not eating fats all the time. It's stored in your bile, in your gallbladder, and then the gallbladder squeezes, senses as it comes down through the small intestines, through duodenum, the first part of the small intestines, and squirts bile on top of the fatty meals, and that emulsifies it. It breaks up the fat so you can better absorb it later in your small intestines.
Okay.
So if it turns out if your gallbladder has stones or sludge, you can imagine like thick stuff like sewage, then your gallbladder can't squeeze, and so ends up that your fats go past it without any bile
breaking
being
down. Interesting.
And so the fats don't break down. The fats you can't absorb it. So the fats cause your bacteria to go berserk, and it also could draw a little bit of fluid in there, so you can diarrhea. It also can cause some of your bacteria to go berserk because there's a lot more nutrients for them to grow off of and stuff like that. And so you end up getting kind of this after meals, a couple hours after meals. It's not right away. You'll get this this bloating and cramping and diarrhea type stuff because you can't absorb your
You
fats.
mentioned that this is something that we're seeing more commonly in the United States. So are these aggravated by kind of the American high fat, high sugar diet?
So yeah, it's not just recently, but it's just for decades now.
Yeah,
that's absolutely correct. Yeah, we see it typically, the old medical school term, fat 40 or 50 infertile. So the unfortunate thing is that it tends to happen more in women.
Yeah.
It tends to be women who are not menopausal yet, so there's in their 20s and 30s and 40s, and overweight and so stuff. Men get it too, but that's it tends to be a rich diet, and is the ones that seem to get more stones and sludge.
Okay, that makes sense.
Cholesterol stones. And stuff. And then endometriosis again is the anatomical. Then surgical procedures, like I mentioned before. There's certain ways that we bypass intestines for weight loss. We do it for whenever you get ulcers in your intestines, and we have to cut out part of your intestines, or where your intestines are bound up in with adhesions, and they may choke off the blood supply. So you have to cut out parts of the intestines and reattach the intestines. So you don't reattach it the way that the good Lord intended. So you end up having making pockets and altering kind of the certain flow, including bacteria, so you can get a SIBO, small intestinal bacterial overgrowth, with these surgical procedures.
Does it not having the like the square footage, the amount of length of the regular, does that impact it very much?
Not unless you have severe removal, quite a bit of removal, which would make you which could cause a severe problem. But no, typically it's not because you've removed so much. Usually, whenever we remove parts of the small intestines, you can remove essentially the whole colon and do fairly well. Part of the small intestines, which is now attached to your rectum, if you don't have a ileostomy bag, then some of the terminal small intestines will get bacterial overgrowth.
Overgrowth. Okay, gotcha. Interesting.
Yeah. Then diabetic enteropathy. So long-standing diabetics, you've heard of sometimes diabetic neuropathy in their feet. They can also get neuropathy to their intestines, so the nerves that control the intestines. So some of these people will have diarrhea, sometimes constipation, but that's because they've kind of they're killed off some of the nerves or made sick some of the nerves because of high blood sugars for so long.
The high blood sugars actually damages the nerves endings.
Blood vessels,
wow, interesting.
Blood vessels and nerves. That's
wow.
Correct.
Okay.
So diabetic enteropathy. So these people can have problems with their peristalsis, the movement from the mouth through the anus. Right. We didn't say this, but from your mouth to the anus is a big long tube.
Yeah.
Essentially, it's a squeeze. It relaxes ahead of the food bolus, and behind it squeezes. So it relaxes in front of it. It squeezes from behind the food bolus. It pushes it down from top to bottom. That's why you can hang upside down and swallow. It squeezes it up even upstream. Then also short bowel syndrome. This is dumping syndrome. So once again, you kind of alluded to this. Sometimes we remove so much of your intestines for a variety of reasons. Inflammatory bowel disease is one of them, like Crohn's, that you don't have enough mileage to absorb everything that you need to absorb. So you can malabsorb. But we cause that by giving you a short bowel, and we call dumping syndrome. When we eat, you end up having diarrhea because there's so much. There's not things move so fast it doesn't have a chance to absorb everything because you've cut out so much of the intestines.
So do you essentially just have to eat very smaller and more frequent meals you can have something called an elemental diet where we have some stuff that's already broken down for you, so the body doesn't have to work so hard to break it down before it absorbs it. So you can have elemental supplements. So elements.
like iron, etc. Then the next thing is fistulas. Fistulas, there's abnormal connections between intestines and other sections of the intestines, or between intestines and your abdominal wall or pelvic organs. So it's a weird setup, but it happens oftentimes after surgeries, sometimes even after GYN surgeries, unfortunately.
Absolutely.
So you can have abnormal connections between your bladder and your vagina, between your rectum and your vagina. So you get poop out of your pee, you get poop out of your vagina. It's crazy stuff.
Absolutely.
But also sometimes fistulas, depending if it's with the pancreas, et cetera, you can end up having GI upset, diarrhea and stuff like that.
And I think sometimes I think of like it's actually like tunnel, like it's a small tunnel, like a small tunnel.
Yeah, it's like sometimes like a pencil.
It's not just like scar tissue branching to touch something new. This is an actual tunnel. Okay, yeah.
They actually it's an opening, abnormal opening between two viscous structures. Vagina, bladder, rectum, colon, small intestines. Yeah.
Sounds brutal.
So yeah. Next thing is chronic pancreatic enzyme insufficiency. So some people will have chronic pancreatitis. Sometimes it's drinkers. People, that's not acute pancreatitis, which is high amylase and lipase and acute pain and fever. Those are people sometimes in the ICU. But chronic pancreas, so if you've had repeated pancreas inflammation, sometimes just chronic mild with alcohol causing inflammation, your pancreas kind of peters out. Your pancreas does two big things. Endocrine pancreas makes insulin that goes to the bloodstream and helps with sugar regulation, and exocrine pancreas, which helps with protein breakdown and carbohydrate, starch breakdown, and fat breakdown. So if your pancreas is sick, chronically sick, because it's been inflamed so much, you sometimes will become diabetic, but also you sometimes will not absorb protein or fats or carbs very well. We have some medicines to replace part of, we have insulin to replace part of it if the pancreas doesn't make enough insulin. We have also enzyme proteins. Pancreatic enzymes that will replace some of the enzymes that break down carbs or starches, proteins, and fats. So these people have to have multiple pills multiple times a day as they eat.
Yeah, wow.
Multiple capsules, yeah. But as you can imagine, if you don't have some of these exocrine enzymes, you'll have diarrhea.
Sure.
As you eat foods, you won't be break down and therefore absorb.
Yeah.
Therefore, you'll end up in your
stool.
So
get anatomical and malabsorption.
Mm-hmm.
Okay.
That's right.
Yep.
One that sometimes we forget about, is, especially after that happens in abdominal pain after meals, and sometimes with diarrhea, is superior mesenteric artery insufficiency. So you have to have a blood flow to every part of your body, including your intestines. Your intestines needs more blood flow after you eat. So it takes a while between your mouth and your stomach, and between your stomach, so maybe 2-3 hours to get through your stomach, and then so several hours after you eat, it will go to small intestines. But if you don't have enough blood supply through the superior mesenteric artery, sometimes that part of intestines cannot handle the food because it doesn't have enough blood flow to come through it. So you'll have belly pain and diarrhea. So that's kind of, some of the stuff is just plain old, you can tell the timing.
Sure.
Stuff like that. Certain types of cancers are weird and rare, but so neuroendocrine. So this is, as you can imagine, is from the nervous system and the endocrinological system tumors, carcinoid and gastrinomas and insulinomas and vasoactive intestinal peptide tumors. Things that you've never heard of and stuff like that. But the end result is that they can also cause GI upset and sometimes flushing and diarrhea, sometimes even hypertension. So they're very, very rare. And like I mentioned before, if you main reason to have small bowel lymphomas is that you have untreated or undiagnosed and untreated celiac sprue.
Sure.
And then the one thing that we have in our older folks, especially in nursing homes, is fecal infections, stool infections, constipation. You say, well, that's easy, but sometimes it's a little high. You can't use. It's not from. So they have loose stools. So you're 5 feet of your colon. People don't realize this. It's liquid after you chew it. It's in your stomach and it goes with the stomach acid juices. It's liquid. Your contents are liquid until the last 2 or 3 feet of your colon.
Right, where the water is reabsorbed.
Whereas reabsorbed, there's a massive amount of reabsorption in your colon. So you can imagine if you're constipated up high, a foot up from the rectum, that there's a lot of liquid backed up behind the solid fecal impaction. So sometimes there's so much pressure that it'll squirt around the solid.
Yeah.
It won't push the solid piece
Right.
out, but it'll squirt around, so you'll get tons of diarrhea, and you'll have cramps and all sorts of stuff. But you have not relieved the what we call high impaction, and so some of these people, oftentimes they're elderly. If you can relieve the impaction, they'll have quite a bit of diarrhea, but then they can get back to maybe a more normal bowel habits.
And so essentially being sedentary can kind of be a real trigger for that, correct?
Yes, there are a bunch of reasons. We as we grow older, we tend not to be as thirsty. We tend not to get up and grab water, so we're less water, more dehydrated on average. If you're more debilitated, we tend to not eat as much fiber for a variety of reasons, including chewing and dentition and dentures, and then and we're not as active. So a bunch of reasons for us. And if we're on antidepressants or narcotics, we tend to become more constipated.
Yeah. Man, okay, so that there are a lot of possible causes for IBS. We certainly have established that today. I think kind of in connection to our previous episode, we were talking about low back pain, kind of how to figure out and pinpoint some of this stuff.
Right.
Obviously, when you go to see your doctor, they're going to be thinking about the most common and likely causes for some of these symptoms. But after that comes the differential diagnosis, right? Where they have to think about all the other possibilities.
They hopefully think of it to get all together, but then they just pick the most likely ones,
Sure.
the easiest one to treat or to diagnose or to go look for first. Yeah.
So what do you suggest to people that are, trying to see their doctors for their IBS symptoms, they're just not resolving?
Right.
How do you get to some of these more specific diagnoses or hard to catch diagnoses even?
Yeah, so unfortunately you have to have somebody who's usually either you have a very interested primary care doctor or typically a GI physician. You end up that's why the number one reason to see a GI physician is irritable bowel syndrome, which is probably IBS or like symptoms, because like we noticed here, not every one of them irritable bowel. By the way, irritable bowel is not. These are all things that are not irritable bowel.
Right.
They mimic irritable bowel,
Yes.
and if nobody's ever going to do all these tests, but if you don't have any of these, then we can call it irritable bowel.
Sure.
Usually they've eliminated. You're not having fevers. You're not gluten intolerant. You can eat. You don't eat artificial sweeteners. They can pretty much eliminate. You don't have to do much to figure some of these things out. So the irritable bowel like symptoms are so that's the other thing. So part of this stuff is kind of make a checklist to say, hey, this is oftentimes they want you to have a food log or whatever. It's kind of like a headache log for people that have headaches. When you get them, is it the weather? Is it what you eat? Is sleep? So food. So you can get a food. You can download one from the internet, kind of a food log, not for calorie counting and stuff like that, but for irritable bowel type stuff to see what the triggers like. Oh, every time I go out and eat a salad at blah blah blah, I tend to have gas and bloating and diarrhea. And so, but if I eat a salad that I make at home, I tend not to have that, even if I use if I make my own dressing. So some people in the old days, we used to think sulfites that they spray on cut vegetables to prevent them from browning. We used to think that some people were sensitive to that. And so we don't fully understand. People. Some people pre-medicate before they leave. They've had quote unquote irritable bowel for so many years. They just pre-medicate. They take Imodium before they leave to go eat at a nice restaurant, so they don't have to get up and run to the bathroom.
Right.
Typically between mouth and rectum, it takes about 24 hours for what you eat to show up in your stool. But some of these people are like within an hour or two, they're it feels like it just races through. Now some of it is of course stuff from the day before, but they literally gurgling and we call it borbigamy, all this gurgling and sucking noises and stuff in your intestines. You have babies. So all that stuff that's sloshing around. Yeah, we actually have a name for it. Anyway.
Wow, that's just delightful.
Everybody should see your face.
So I guess this sort of comes down to how can I avoid a lot of this?
Yeah, so certainly I think
isn't even avoidable. I mean,
certainly exercise and decreasing stress helps in sleeping right and eating fiber. Balance. I'm not telling people to be vegetarian or vegan. Balance. As they say, is colors. All sorts of colors of vegetables, so you can get everything from fiber to vitamins to some other important chemicals. I think there's something like 30,000 chemicals in the foods that we eat. These are natural parts of not chemical
Not synthetic chemicals.
Not synthetics and stuff. So our diet is. I think we need to just have a cleaner eating. It doesn't have to be non-GMO and stuff like that. But some cleaner eating tends to help, I think.
Less processing.
Right.
Yeah.
Right. I think,
less added sugars, less refined oils, those kinds of things.
So that's some of the problems that we run into, is that they suck up all your calories and stuff, and then you don't feel like eating some of the more healthful stuff, because you could pack in so many calories with the soft, mushy stuff that's been processed. But anyway, so the end result is, start like with some of that general health, and it hopefully helps you with your energy and don't have as much feeling sleepy after lunch and all that stuff like that.
Sure.
But you should be able to get people should know that they get however many bowel habits. If somebody will ask you how many bowel movements you have per day, have you had any change in your bowel habits, increase or decrease, have you changed the consistency, are you now having diarrhea when you used to have more firm and stuff. So some of the stuff they'll ask, and you'll say, I don't know, but you can take a couple of weeks and just scribble it down in some sort of a simple chart. It makes a nice difference for you to understand and for your doc or whomever.
Are there other environmental irritants like alcohol or smoking or anything that can aggravate some of these symptoms?
Yeah, I've not seen specifically smoking and alcohol. Actually, smoking they use nicotine for inflammatory bowel disease. Believe it or not, as nicotine patches, we don't want to give people, but it can help with certain inflammatory, like Crohn's, if I remember correctly. But anyway, typically I've not seen it directly. Some people will can obviously say that
there's a connection,
right. If they have certainly for people with gluten problems, beer, typical beer that's not gluten free can be a significant problem. Gotcha. Some people unfortunately if they're gluten, they end up doing wine and hard liquor. That's for them the trade off. It's like, I can't have beer, so I'm like, no, it's not a good trade off. So I've not seen it directly. It's interesting. I've not seen it as much specifically with kind of these belly and bowel symptoms.
Yeah. Okay, but people can use all of the good, tools that we were suggesting in our previous episode too about getting some of this stuff. WebMD and Mayo Clinic will be sources for these like long lists, like clearinghouses of information for all of the possible things that could be contributing.
WebMD.com and MayoClinic.org, O-R-G.
Right.
Those are really, they do a nice job of collecting all this information in easy to read form.
And as you've said before, the doctors are looking at similar resources too. These are the types of resources that are not that your doc is getting on WebMD in between seeing you, but their sources of information are similar for those kinds of sites, and it's okay and good to be educated about the different things that could be. I want people to be
educated. I want people to ask questions, and so hopefully your doc could say, if they say, gluten enteropathy, this tends to be Northern European genetics, and you're not Northern European genetics, so it's unlikely there's going to be that, and that's fine. This is appropriate. When the doc should be able to say a few sentences or look up something and be able to tell you why yes or why no that you're right or wrong, and what you've read about that applies to you specifically.
Sure, absolutely. So those resources can be really a valuable tool. Obviously, you're not diagnosing yourself and looking for the worst possible scenario. No. In looking at that, and you shouldn't freak yourself out by saying, "Oh, look, my symptoms all line up with cancer. I must have a deadly cancer."
Right.
But just knowing that here's a list, here's a resource that can give you a list of possibilities that you can ask more informed questions to your doctor about. I want people to come in with kind of an idea, like anybody. If you go to listen to a lecture, they want you to have, ask intelligent questions and stuff like that. So that means you read up or you're interested in the topic, and it's your body, and it's some of these things are chronic, and so you're going to have it for a long time to come. It's, a lot of stuff, I think, as I was thinking about this the other day, a lot of stuff we should start off as I want people to reprioritize their health a little higher up, their kids and their spouse or their partner and their church or synagogue or temple, and 2, 3, and somewhere down there your irritable bowel that bothers you. Right.
Sometimes I have to say maybe some days to kind of prioritize. Sometimes it'll prioritize it for an hour hour or two, whenever you go see the GI doctor, they're out of there. As soon as they're out, anything that's been written down or handouts or they're out of there. They're like, the next time I see you, I'll look at it the night before.
Yeah.
So
absolutely. Okay, well, thank you for sharing your wealth of knowledge with us. This one's once again taken directly from the Not Your Doc blog, which will be linked in our brand spanking new website that Seth is going to be rolling out for us soon. Is it notyourdoc.com? What is
Yep,
it? Yeah.
that's right. That's correct.
Notyourdoc.com, coming soon. We'll let you know when that goes live. In the podcast description for this episode, we're going to have some more resources for you as well to look at this, some links that Dr. Tadros suggests. As always, if you want to send us any specific questions or get involved with the podcast, you can send us an email to notyourdocpod@gmail.com. We always want your feedback and participation. We're going to have a lot more discussions like this. Hopefully some guests coming up here pretty soon. I'm looking forward to that.
We're going to have them stretched out probably through the spring. Yeah, some guests. So we're looking to have a general surgeon who has probably 40 years of experience, sleep medicine physician who's also intensive care unit physician, and lung doctor.
Yeah.
And I'm going to try to get a couple of pain management specialists, and one of the our local addiction specialists.
Yeah.
So we have some good topics that we see and deal with a lot, and
Right.
we have specialists that know much more than I do. So
For sure. I feel like we're making good on some of the promises or,
Right.
things that we highlighted in
Right.
our pilot episode last year.
If people want to hear about non-medical items, I'm always happy. We have friends who are attorneys and friends who are English teachers. I think a lot of stuff is that makes people interested in listening to us and thinking about things is cool for us to highlight.
Absolutely. It's good to be with you all today. I'm Vanessa, and with Dr. Tadros and Seth, we are signing off for now. Thank you very much.
See you later. Bye-bye. This previous podcast represents my opinions and the opinions of my guests. This is not medical advice, and I'm not establishing a physician-patient relationship with any listener. The content here should not be taken as medical advice. The content here is for informational purposes only, and because each patient is so unique, please consult your healthcare professional for any medical questions that you may